In this video lecture, we'll be discussing the history of the Diagnostic and Statistical Manual of Mental Disorders, which is the primary diagnostic and classification system used in clinical psychology in the United States. So the Diagnostic and Statistical Manual of Mental Disorders, often known as the DSM, is a text that's published by the American Psychiatric Association, and it is a diagnostic and classification system for psychiatric disorders. So it's a system that provides diagnostic criteria that are used to give diagnoses to individuals on the basis of the symptoms that they are experiencing. It's also a classification system that groups different disorders and diagnoses together with one another and organizes them. And it's focused on psychiatric disorders, so disorders that we consider mental illnesses or psychiatric or psychological in origin and presentation. So one important characteristic of the DSM is that it is explicitly a descriptive classification system, and this differentiates it from many other classification systems in medicine that tend to be based on causes of illness. So for example, if you go to the doctor with a sore throat, they're not going to diagnose you with a sore throat. They might diagnose you with a strep infection because your sore throat is caused by a strep bacterium, or they might diagnose you with COVID-19 if your sore throat is being caused by a coronavirus infection. So unlike those classification systems that are based on causes of illness, the DSM is explicitly a descriptive classification system that classifies disorders on the basis of their observable characteristics. So in the DSM's own words, it is a classification of mental disorders with associated criteria designed to facilitate more reliable diagnoses of these disorders. So one of the primary goals of the DSM is consistency in diagnosis. So if a different clinician was given the same information about a patient, that clinician should come to the same diagnostic conclusion as someone else who was given that same information. So the goal of the DSM is to have a standardized system by which we group symptoms and disorders together to give individuals diagnoses and to group those diagnoses together into different classifications of disorders. So before we start talking about the DSM, I want to talk a little bit about the history of diagnostic systems, particularly about diagnosis within a United States context. And historically, the goal of diagnostic systems has been to collect statistical data regarding mental illness. So for example, from a public health perspective, it is important to have a sense of how many individuals in a community might be affected by mental illness. That might affect your distribution of resources, where you are putting money, where you are putting community health centers, and also getting information about groups that are at risk or groups that are at decreased risk so that you have an understanding of your population and its needs. So one of the earliest examples that we have of a classification system that was used to collect this data in the United States is the 1840 census. And in the 1840 census, they recorded the frequency of two characteristics that were relevant to thinking about psychiatric disorders. They included idiocy and insanity. One thing that I think is important for us to note is that the history of diagnosis, diagnostic systems, and the classification of psychiatric disorders is very deeply entwined with systemic racism and with eugenicist movements. So for example, shortly after the census in 1851, Samuel A. Cartwright, who was a physician in the southern United States, proposed a new psychiatric disorder called drapetomania. And the primary symptom of drapetomania was when an enslaved person would attempt to escape. So this was seen as a symptom of a psychiatric illness that was characterized as a disorder. And these categories of idiocy and insanity were also used in the eugenics movement to identify individuals who were considered to be less valuable to society, and there were laws and policies and practices designed to discourage or prevent reproduction by these individuals with the goal of improving the genetics of the whole population. So in the history of these diagnostic systems, it's important to note that historically groups that have been in power have used their definitions of wellness and of disorder to wield and to shape structural power, particularly in this case we're talking about in the United States. In 1880, we see the census expanding to address additional categories. So we go from 2 categories to 7 categories. Some will sound familiar. Some are terms that we no longer use. So the categories assessed in the 1880 census included mania, melancholia, monomania, which is a kind of obsessional interest, most similar to what we currently characterize as obsessive-compulsive disorder. Paresis. Paresis was often used in the context of general paresis. These were physical symptoms and also dementia that were associated with the late stages of syphilis. Also, sometimes this was used to characterize symptoms that we now consider consistent with schizophrenia and other psychotic disorders. These also included dementia, dipsomania, most similar to current alcoholism or alcohol use disorders, and epilepsy. In 1917, we have another major advance. So in 1917, as we are heading into World War I, the American Medico-Psychological Association and the National Commission on Mental Hygiene collaborated to publish what was then called the Statistical Manual for the Use of Institutions of the Insane. So here we can see a couple interesting historical threads coming together. So the National Commission on Mental Hygiene is involved. So just like with the census, we can see that we are using this as a political tool to collect statistical data about the population. We are also seeing the growth of psychiatry as a medical specialty. So you might notice the name of this organization. It is the American Medico-Psychological Association. So American psychology is working to differentiate itself from its European counterparts. And this is a medico-psychological association. So it's not just psychologists, but this is attempting to define itself as a medical specialty. Another thing we can see is that this is a diagnostic manual that is specifically designed for institutions for the insane. So this is going to be focusing on the kinds of disorders that were typically presenting in institutional settings and more severe psychiatric disorders. And we're continuing to see this theme of an increase in the number of diagnostic categories. So we've gone from 7 categories to 22 categories. Now we're going to jump forward to our next World War, and shortly after World War II, the World Health Organization published the ICD-6. So ICD stands for the International Classification of Disease System. So this was the 6th version of the ICD, and ICD-6 was the first ICD that included a section on mental disorders. So in the ICD-6, there were 10 categories for what they called psychoses and psychoneuroses, and an additional 7 categories for disorders of character, behavior, and intelligence. So here we have a diagnostic system being published. This is not an American organization. This is the World Health Organization, and they are publishing this first major diagnostic system for the world that is incorporating these mental disorders in addition to these physical disorders. In response, we get in 1952 our first version of the DSM. This is the DSM-I, and it's published by the organization that is now known as the American Psychiatric Association. So in America, we are not going to use this World Health Organization classification system. We are Americans. We write our own books. So American psychiatrists publish their own diagnostic and statistical manual. So the DSM-I was the first official manual of mental disorders that emphasized clinical use. So unlike the ICD-6, this was specifically a manual for mental disorders, not including mental disorders with physical disorders. And it was not designed like the census to collect data for government use, was not designed for research purposes. It was designed to be used clinically, designed to be used by psychiatrists and other treatment providers in assessing individuals and helping those individuals. The DSM-I in structure looks a lot different than the current version of the DSM, and the DSM-I presented disorders with a glossary that provided descriptions of diagnostic categories. So the DSM-I included 106 different disorders. In the DSM-I, these were called reactions. And the way that these reactions were defined was with a really rich textual description. So there might be a few paragraphs describing what this disorder or reaction tends to look like. So unlike modern systems that we're used to, where you might see more of a checklist approach that defines specific symptoms and says, if these symptoms are present, you meet criteria, this was a much more narrative approach. There would be paragraphs that would describe a disorder, and the clinician would assess their patient and determine which of these descriptions sounds the most like what my patient is experiencing. So these disorders were called reactions, and this is reflecting a very psychodynamic orientation. So characteristic at the time, many clinicians were guided by a psychodynamic perspective that grew out of Freud and related theorists' work. So the DSM-I, our first diagnostic and statistical manual, is really grounded in that psychodynamic approach. So we used the DSM-I for a while, until we get to 1968, and then we get our first major DSM revision. Now we get the DSM-II. In the DSM-II, we eliminate the use of the term reaction. So this is kind of early in the process where American psychology is shifting from a more psychodynamic clinical approach to a more cognitive and a more behavioral approach. We've also got a really strong influence of humanistic psychology at this point. So the DSM is moving away from this psychodynamic approach, and it stops using the term reaction. And it also expanded. So we go from 106 reactions to 182 disorders. We make it now all the way until 1980 before we get our next revision. And the shift from the DSM-II to the DSM-III is probably the greatest shift that we see in the history of the DSM. So there are some major changes between DSM-II and DSM-III. So one shift is that the DSM explicitly defines itself as a descriptive classification system that is neutral to underlying causes. So continuing this process that started with DSM-II, where they got rid of the term reaction to start to distance themselves from that psychodynamic approach, in the DSM-III, the classification system is purely descriptive and not allied with any particular theoretical approach. It also introduces explicit diagnostic criteria for each disorder. So unlike the glossary approach of the DSM-I and the DSM-II, where we're having these descriptions and a clinician is looking to see which description is most consistent with what their patient is experiencing, in the DSM-III, we introduce the kind of system that we currently use, where there are specific symptoms for each disorder that are defined, and there are explicit criteria for what is required to give an individual a diagnosis. The DSM-III also introduced something called the multi-axial diagnostic assessment system. So in this system, a full diagnosis for an individual included 5 different components, and these were called axes. So axis 1 included most clinical disorders. So these are going to be the categories of disorders that we are going to talk about later this semester. Mood disorders such as major depressive disorder or bipolar disorder, anxiety disorders, trauma-related disorder, obsessive compulsive disorder. All of those diagnoses would be classified on axis 1. On axis 2, the The DSM classified what was then known as mental retardation and also the personality disorders. So these were disorders that were seen as more long-standing and more pervasive in their effects. So they were separated from the Axis 1 diagnoses and what's now called intellectual disability and also the personality disorders were diagnoses that were given on Axis 2. Axis 3 is where a clinician would indicate medical conditions that were relevant to a person's psychiatric diagnoses. So for example, if you have a patient with hypothyroidism, that might be important to note if they're also experiencing symptoms of major depressive disorder, because the symptoms of hypothyroidism, things like low mood and difficulties with sleep, are similar to the symptoms of major depressive disorder. So on Axis 3, you would note any relevant medical conditions. On Axis 4, you would denote any relevant psychosocial characteristics. So you could note, for example, problems with housing situations, employment loss, recent divorce, stress in the family, global pandemic, anything that a person is experiencing in their social life that is relevant for contextualizing and understanding their symptoms and diagnosis. And then finally, Axis 5 was the Global Assessment of Functioning, or the GAF. And the GAF is a 100-point scale. It goes from 0 to 100 that provides a quantitative global summary of an individual's level of functioning. So a GAF of 100 would be totally optimal, flourishing functioning with 0 problems. I have never met anyone with a GAF of 100, and if I did, I probably wouldn't like them. GAFs over 90 are people who are doing really, really well. They're not experiencing symptoms, they're not experiencing distress. Overall, they're functioning well across domains. And as GAF decreases, you're seeing increasing symptoms, increasing distress, and increasing impairment. So this multi-axial diagnostic system was designed to encompass many different facets of well-being in giving an individual a diagnosis. And an interesting thing about the DSM-III is that this is the point where the American Psychiatric Association explicitly identified the goal of the DSM as providing precise definitions for clinicians and researchers. So facilitating both clinical practice and also research by providing shared definitions of psychiatric disorders that could make diagnosis more reliable and consistent across time, across location, across individuals that would facilitate clinical work and also facilitate research. So the DSM-III was used for quite a long time. We don't get our next revision until 1994 when we get the DSM-IV. The changes from the DSM-III to the DSM-IV were comparatively minor. It expanded to include more disorders. So DSM-IV, we are upward of 300 different disorders. And in the DSM-IV, we shift so that making revisions to the DSM requires empirical research. So you can see a stronger emphasis on research and a scientific approach to defining disorders and categorizing disorders and making changes to the DSM-IV. So from DSM-IV, that leads us to the DSM-V. DSM-V was published in 2013, and this is the version of the DSM that is currently used in the United States. So the DSM-V revised some diagnostic categories and symptoms to be consistent with new research evidence. So aligned with that requirement from the DSM-IV, based on new empirical evidence, there were changes made to the division of diagnostic categories, the existence of specific diagnoses, and revisions of symptoms. So if you have read the example article for the research report assignment, you'll have seen information about one of these changes, and that was the shift from autistic disorder and Asperger's disorder in DSM-IV to what is now defined as autism spectrum disorder in the DSM-V. So in DSM-IV, these disorders were part of a group of disorders called pervasive developmental disorders that were characterized by symptoms related to communication, social interaction, interests, and repetitive behaviors. And in DSM-IV, there were two distinct disorders. There was autistic disorder, which was considered more severe and characterized by delayed language. And then there was Asperger's disorder, which was considered less severe and did not have that characteristic language impairment. But over the time that the DSM-IV was used, research evidence was starting to suggest that this distinction between autistic disorder and Asperger's disorder was not really reflected in the empirical evidence. So for example, when you looked at different kinds of symptoms, when you looked at functioning, when you looked at responses to different kinds of interventions, you were not seeing the same kinds of differences between individuals with autistic disorder and Asperger's disorder that you might predict based on that classification. So based on this new research evidence in the DSM-V, these have now been combined into an overarching category of autism spectrum disorder that has some additional specifiers that can be used to characterize things like whether there's the presence of a language impairment or delayed language development. So in the DSM-V, we have changes to this diagnostic system that are based on new research. DSM-V also eliminated that multi-axial system. So we are no longer using those different axes. Some of the language that was used in DSM-III and DSM-IV is now no longer relevant. So if you're ever reading an article published before 2013 and it talks about something as an axis 2 disorder, that's reflecting that earlier multi-axial system. But since 2013, we have not been using that system. The DSM-V also proposed changes to the classification of personality disorders. So like all of the previous editions of the DSM, the DSM-V is a categorical system. So you either meet criteria or you don't, and we have diagnoses in these different categories. For the DSM-V, there was a well-developed proposal to shift to what's called a dimensional system for personality disorders. So thinking about a spectrum of personality traits and characterizing individuals in terms of where they fall on that spectrum, as opposed to a categorical system that says you are in this category or you are not in this category. This was ultimately not implemented for DSM-V, but it is still proposed as a potential future system. And there's a lot of active conversation right now about not only for personality disorders, but for many other kinds of disorders, whether a categorical approach is most appropriate or whether a dimensional approach might be a more effective or more accurate approach to diagnostic systems. So we'll wrap up by talking about the DSM-V and how the DSM-V defines mental disorders. So in the DSM's own words, a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. So in this definition, you'll probably recognize some of the different approaches to distinguishing abnormality that we discussed earlier. So when we're talking about clinically significant disturbances, we are considering how much a disturbance differs from what is expected. So we can think of that as being relevant to deviance. So in a clinician's judgment, is this experience or disturbance clinically significant? Is it different enough from what is typical? We explicitly see the assumption of dysfunction, so some kind of dysfunction or pathology in normative psychological functioning or a biological process or a developmental process. We're seeing distress or disability, so it's causing distress or impairment in social or occupational functioning or other important activities. So that's consistent with our dysfunction approach. And another thing we see in this definition is that it is encompassing a wide range of mental experiences. So it might be reflected in cognition or thought, it might be reflected in emotion regulation or affective experiences, and also in behavior. So this is a fairly broad definition. There are, however, a few things that the DSM explicitly excludes from its definition of a mental illness. So one thing that the DSM-V excludes is an expectable or culturally approved response to a common stressor or loss. So for example, feeling intense distress or sadness at the death of a loved one would not be classified as a mental disorder in the DSM-V. And another thing that is explicitly excluded from the DSM-V definition is socially deviant behavior and conflicts that are primarily between an individual and society, unless that deviance or conflict results from dysfunction within the individual. So if there is conflict or a problem related to conflict between an individual's political beliefs or behavior, religious beliefs or behavior, sexual beliefs and behavior, and the expectations of their culture or legal expectations, unless that conflict is driven by dysfunction within the individual, that conflict between the individual and their societal context would not be given a diagnosis of a mental illness.